everyone to this webinar on supporting particle investigations with risk-based decision making. I am Scott Ewan. I'm a global change facilitator with BioPhorum, so I'm your host for today's webinar, but not one of our technical experts, so please don't direct any technical questions to me. But I do want to just get started with some housekeeping for the webinar. We are recording, so please be aware that we are recording. We will have a Q&A at the end of the session, but during the main presentation, it's probably wise to set your cameras to off, and please also turn your microphones off if they're not already off, so keep things silent. Feel free to ask questions in the chat. I will be monitoring the chat and will raise questions with our speakers when we get to the Q&A section at the end. I mentioned we are recording the session. The session will be shared over the next coming days. And any questions we don't get to in the Q&A session, we will provide written responses to those questions, which we will share at the time of the recording. So straight into the introduction for the session. This webinar is presented by BioPhorum, but this is a public webinar open to non-members of BioPhorum, so everyone is very, very welcome, and thank you for giving us your time this morning, afternoon, to join the webinar. BioPhorum is an environment for collaboration across the global biopharma industry. We bring industry leaders and experts together. We build communities to create positive change for the industry. Across our 10 forums, we have over 75 work streams, and the visual inspection work stream presenting today is one of those from within our fill finish forum. The visual inspection work stream itself is made up of over 70 leading subject matter experts from around 30 member companies, the majority of whom have contributed to the work presented today. I should also mention as well that the work the team will describe today is all available for download from our website without charge at a link that I'll add to the chat towards the end of the presentation today. This slide just serves to illustrate the breadth of activity within BioPhorum, and you can see where the fill finish forum sits within the broader picture of BioPhorum as well, and all of these areas that we also cover. But our team, as I mentioned, is focused very much on fill finish and the visual inspection work stream within that. And I'm now going to hand over to the team to introduce themselves. So over to you, Valerie.
Hello, everybody. So I am Valerie Rautureau. I am working at Eli Lilly as a visual inspection expert, and I am located in France.
Okay, then I will follow. My name is Marcel Uijlen. I work at Organon. Organon is a spin-off from MSD, Merck in the US. And I am a microbial contamination and VI expert at Organon, and probably one of the few that are still on this team because we started a long time ago. So I'm there from the beginning. Antonio?
Thanks. My name is Antonio Burazer. I'm with Takeda. My role in Takeda is global head of visual inspection. Anybody on the call, could you please mute your microphones? We get some additional noise. Thanks a lot. So my role is head of visual inspection and particle lifecycle management on a global level. We have quite a bunch of sites across the network, and I am happy to actually manage the visual inspection processes, but also everything around particles from the very beginning to the very end. And delighted to be here. Started to join the group in 2019 and have already been able to join a lot of interesting sessions. So happy to present today.
Fantastic, thank you. So moving on into the background, I think we're sticking with you. Moving to Marcel, actually. So back to you, Marcel, if you're ready to go. Marcel, you're on mute.
Yeah, sorry for that. Yeah, so you see here a slide, and I'm not going to tell everything, read everything what's on this slide. You can do that on your own. But I want to tell a few things. So I think that everybody on the call knows that a major cause of parenteral products recalls is due to particles. So it is very important to reduce the introduction of particles, but as everybody knows, it's not possible to have zero particles. Therefore, it is important to manage the risk when particles are found. And dependent on the particles being typical or atypical, the outcome of the risk assessment where we are going to talk about can be fully different. So with the tool presented today, we offer a framework to support investigation due to particulates, and there's a systematic assessment of the risk to the batch. So in fact, we are using a risk assessment like is mentioned by ICH, where we use the different terms that are mentioned there. And looking at the USP 1719, it is possible that you say, okay, it looks like that not every particle should be shown as critical when as you look at the AQL level there. So next slide, please. Yes, as mentioned during my introduction, the whole journey of particle classification started already some time ago. In fact, in 2018, the proof of concept paper was published which describes a risk-based standardized methodology for classifying visible particles in parenteral products. We did not come up with new risk factors, but used info already available published by different others, like John Ayers and Stephen Langell, who was previously at the FDA. So with that, the team created a standardized approach that generated a risk number for a visible particle in any given product. So it can be that for one product, it could be critical, and for another product, it could be that the same kind of particle is not critical, but major. So I do not want to go into much detail on that methodology here, but when we came up with this method, the team immediately saw the importance in applying this approach also in particle investigation. So we started working on creating version 2 of the standardized approach, which you can see on the screen and which we'll be talking about over the next 30 minutes. So I think I'm now going to hand over to Antonio.
Thanks a lot, Marcel. So I'm delighted that I'm allowed to introduce the tool today. Scott, if you just could advance to the next slide. Perfect. So first question that we need to ask ourselves is what would actually trigger one of those particle investigations? And we have here on the screen, we have a couple of examples that are also listed in the published paper. So if we look at, where in the entire process chain we would find particles, we divided it, and these examples only, into what would happen before 100% visual inspection, during 100% visual inspection, or after that process step. So before visual inspection, you could detect any sort of particles, for example, during incoming material inspection. Those could be in empty vials, in packaging containers, in any kind of raw materials, something that you would find that either, is unusual or that would exceed also specification limits. It could trigger an investigation. During 100% visual inspection, this is very interesting to look at because, as Marcel already outlined, there is no 100% particle-free process. So the question that we need to ask ourselves if we find particles is, first of all, are those particles typical to our process, or are those atypical, unknown, unexpected, something we've never seen before? But the second question that we need to ask ourselves is, what is the frequency of occurrence of those particles? So as we talked about, there is no zero level that we can consistently achieve. We will have a certain baseline, and we will have our trends, we will have our action limits, and we will look at, whether this is like normal occurrence or if the occurrence is actually atypical, even though the particles are typical for the process. Furthermore, we could detect particles after visual inspection, either during, acceptance testing, could be AQL, supplemental testing. It could be based on health authority requests or complaints. So all these different items, and that's not a comprehensive list, those are just examples, could actually trigger particle investigations. The important thing to understand is every company needs to define and determine what is their threshold, what would be a trigger for those investigations at our company. Regardless of the trigger, every time we would do a very thorough assessment of those particles, we would assess the risk, and we would also try to understand what is the actual risk to the batch. In the end, we need to determine what are we going to do with the batch. And also very important to outline, the tool will in the end not be able to, make the decisions for you. It will be a standardized tool that will provide assistance, that will guide you, that will give you additional understanding, and it will be one part of your overall risk management process. It will not be the only part. So can I have the next slide, please? Here we have a generic investigation flow. Of course, it is an example and it will not be 100% fit for every company. You will likely have your own process flow charts, but it is a generic one that captures the most important items. So starting at the very beginning, where we discussed about what is typical and known and potentially atypical, if we have atypical particles, and for us, again, we will need to determine what is typical, what is atypical. How would we do that? An example would be to actually establish a sort of library, a reference library that we can tell what is typical to our process. If we have a non-matching material that is not captured in our reference library, we could consider it atypical. It might turn out in the overall investigation that it is typical and belongs to the process, but we didn't see it before, so we can update the library. That's part of the continuous improvement process that we have here. Anyhow, if it's unknown or atypical, we would do a particle characterization. So we would identify the material, we would try to understand the material composition, which can feed into our overall investigation so that we are able to determine what is the source, what is the root cause, what was the route of introduction. Those are the items that we try to capture in the what we call here gather information process assessment step. That's the actual investigation. You will likely form an investigation team. You will likely assess a whole bunch of different items that you can capture in an investigation standard in order to get down to what is the root cause and the source. In the end, you will need to perform a risk assessment, and this is where our risk assessment tool actually comes into play. Very important factor is the potential patient impact when we talk about particles. So we want to understand what if we missed the particle and it was administered to a patient, what would be the potential effects to the patient? That's one aspect of it. But what we take into account too is in order to make a full assessment and understand not only the risk to the patient, but the overall risk to the batch, we take into account the severity. We take into account the occurrence, so how many particles are we actually facing? But furthermore, we take into account what is our capability of actually detecting those particles. So how good are we in removing them from a batch? We talk about the tool in the next couple of slides. But the next step is actually once we have understood the risk, the impact assessment, what is the impact to the batch or batches or the process, and we would potentially be able to come up with mitigations. A mitigation could be, for example, doing a reinspection to increase our detectability if it was low in the first place. If we had, for example, automated inspection, and that's a defect that's hard to detect in automated inspection, we could consider changing the method for the reinspection to increase detectability and then do a reassessment again. In the end, we will need to come up with a conclusion and determine what are we going to do with the batch. And the tool is going to support us in making that decision. So let's look at the next slide. This is the first element. So this is about the severity of the particle. The severity is the same thing as the patient impact that we talked about. So as Marcel explained, we used published guidance that is available in order to determine the ranking and also the aspects that we want to take into account when looking at the severity. Furthermore, the tool was also reviewed by experts to give us more guidance and also fine-tune the methodology that we present here. So what is important to take into account is the patient exposure. And when we talk about the patient exposure, we would be looking at, for example, the volume or the fill volume of the product. We would look at the type of the product. We would look at the patient population. We would look at things like the route of administration. All these together will give us a chance to assess the patient exposure. Just to give it a couple of examples, if we had a low volume product, which is a subcutaneous administration that is administered once in a lifetime to healthy adults, it will likely have different results when compared to a high volume intravenous infusion that is administered to elderly or chronically ill patients on a frequent basis, like daily or weekly. So these are the things to take into account. We also look at the particle size. Generally speaking, the larger the particle, the lower the risk. That's also important to come up with that final ranking. The particle type, whether it's typical or atypical to the process. We would look at chemical compatibility to understand if there is any toxicological risk to be taken into account, but also the amount of particles. And here we specifically talk about the number of particles that we experience in single containers, because that's what a patient would actually be facing when the product is administered. It's not about the number of units affected in a batch, but specifically how many particles do we see in single vials or syringes or whatever the container type is. So for all these elements, we look at either low, medium, or high ranking, and we gave those numbers. So low would be a 1, medium would be a 5, and 9 would be a high ranking. When we combine all those together, we will yield an overall severity score, which we can take a look at the next slide. So here again, it's explained. The table on the upper slide or the upper area of the slide actually outlines all those elements and gives a ranking to either low, medium, or high. Okay, we'll take questions at the end. We have, for example, the patient exposure with low, medium, and high, as explained. We have for the sizes of particles, just examples provided. And this is something that we need to calibrate, in every company, whether this applies to the product that we have on hand, and we can actually use those reference sizes. But generally, the larger the particle, the lower the risk again. And then finally, we have also the amount per unit. And this is also guidance. Like if it's usual to see 1 to 3 particles, we consider that rather a low amount per unit or container. And if we have like many particles exceeding even 10 or too many to count, this would be very high. So this is something that would definitely get a higher ranking. So in the example, in the table below, we see just an example calculation thereof. So we have a potential patient exposure, which was ranked high, medium size, and typical particle. Chemical compatibility was not a concern. We found not only 1, but more particles per container, but not loads of particles. So when we now combine those values, we multiply them, we yield an overall severity score. In our example that we have on the screen, the overall severity score is 225. This is the value that we actually take to the next step. So the next step is actually the calibration and understanding what does the score mean in terms of the severity. Is it low, medium, or high severity? And we have those values scored into those 3 sections, low, medium, and high, and then we can compare the actual value in which of those buckets it would fall. In our example, we have a medium severity result, and in the next step, which is outlined by the number 2, we compare, we take also into account the frequency of occurrence. So the frequency of occurrence could again be low, medium, or high. We try to keep the tool very simple. And low would represent, in this case, our baseline. So we have either, very low levels of particles or expected levels of particles, which are comparable to, historic performance. Medium, we called elevated levels. So it would be higher than usually expected, but probably not hitting the threshold of exceeding action limits. And then in high, we would have unusually high limits, something that is really atypical for our process. We would consider of high frequency. And then the third item and element that we look at is what is our capability of actually detecting those particles. And now it comes down to whether we have the information of our process capability, potentially, assessed via threshold or probability of detection studies. We can assign numbers, percentage of probability of detection to it or not. So if we can, we would use the NAP methodology and sort it into 3 groups. High probability of detection would be a score of anything between 70 and 100% probability of detection. That means it is very reliable. So we can call out this type of particle and this size of particle very reliably. Medium would be anything between 30 and 70%, and low probability of detection is anything below 30%. So that's a very hard to detect particle, a low probability, which results in a higher score. So finally, we take all these together. In the next slide, Scott. Thank you. So in the next slide, we have 2 tables. In the first table, we combine the severity that we assessed together with the occurrence of the particle. So in our example, we had a medium severity with a rank of 225. So now we need to understand what is the occurrence of the particle that we are actually looking at. Did we exceed action limits? Did we have like a shift or trend, something that did not hit the threshold of action limits? Or was it in the typical process performance? This would result in either high or medium ranking for the overall risk to the patient. When we have this result, we transfer it to the next chart. The next chart is actually taking into account the overall patient risk together with our probability of detection, so with our inspection capabilities. If we start with a medium overall patient risk and combine it with the detectability, whether it's low, medium, or high, we will now understand what is the potential overall risk to the batch. Again, taking the example from above, we start with a medium. We could end up having a medium or a low overall risk to the batch. The overall risk to the batch is the result of the tool. So that's what you get, and that's what you can use in your overall risk management process and in order to come up with your final batch disposition decision. So we want to understand how we can actually apply this, and therefore we have a couple of case studies, and I'd like to hand over to Valerie and Marcel to explain those case studies.
Okay, so Marcel, I think you're up first.
Yeah, correct. So let's start with the next slide. Yeah, thank you. So when we look at this, this is about a company who used the standard methodology and risk classification tool to reassess a particulate. And we have now 2 slides which will show that it depends on the input, what the final outcome is of the total score. So we have now the first slide, and it is in fact the risk-based approach to ensure that the visible particles are the response to it is appropriate. So this company had also a few other things that are important for them. So they say, in fact, they must identify the particle positively, and by saying that is that it should be an intrinsic particle. We were discussing before that we said, okay, we're looking at the amount of particles. Anthony was talking about that. This company is looking a little bit differently and say we do not want more than 2 particles, visible particles, in one container, because when we go up, if they think the risk is getting higher, we don't want that. And also a criticality assessment must be performed, and the criticality depends on where do those particles come from in the process? Is it indeed an intrinsic, or is it coming from somewhere else? So we would like to have those materials characteristics as Antonio was telling about. We also look at the defect history. They also look at the defect history. So they look at what are the complaints and deviations we had for this type of particle. Did we have that? And if we also look at this type of particle, what did we do to improve to improve and have a corrective and preventive action in place to prevent those particles coming into the process. So when all that is done, we also look at the medical assessment, so the route of administration, the patient status, and others. And all that outcome is then we would like to have that outcome then of risk remote or less. So if you look for instance for this particle, you will say one of the most important things that you look at is sterility guaranteed? It should be yes. If it is no, you don't go further with that methodology because you don't want to get a patient get something there that could not be sterile. So that's one of the most important things. And then you see the different things. How is it? How is the route of administration? What is the patient's exposure? And it's good to see here when we say, okay, this company looked at, okay, when we have only one dosage of unit per day, then we score a 5. And we can say then, okay, we see it as a low risk. If you go to the next slide, you see the same. Scott, can you go to the next slide? Okay. So if you look then to this part, then you see that in fact it's all the same, the same kind of particle, the same kind of route of administration, but here you see that the exposure to the patient is higher. It's more than 1 dosage unit per day, so then it becomes a 9, and you see there also that the values of the total risk score are going up. So it depends where you put it. So this one is 1125, so it is a higher risk, and the other one is still 225, so it's more in the middle. So you see that it depends on how you score this, what the final outcome is. So I think then I will hand over to the next one who has some other case studies. Antoinette, you do it.
Okay, thanks, Marcel. Valerie, are you ready?
Oh, Valerie, yeah.
Yes. Yes, so I will now show you 2 case studies that could commonly occur in routine manufacturing processes. They will show you an example of the way to use the tool, and it is really the way we are using it daily. So the first case is linked to one isolated atypical particle. When I say atypical, it's in nature, not in level. So we have one atypical particle that has been detected during visual inspection. In that case, we will first evaluate severity. So based on what was presented above, we will quote regarding the probability to patient exposure. So in our case, it was mainly driven by the fact that it was a daily injection. So it was a quotation of 9. The size of the particle was big. It was over 500 micron, quotation 1. And the particle was considered as atypical because it was extrinsic based on the nature of the particle. So the quotation was 9. We also assess physicochemical compatibility and sterility. So all this was considered as no risk, no impact. The particle was sterile for sure. Otherwise, we could not apply the tool. In that case, the quotation is 1. And as there were only 2 particles in one unit, the amount was at the quotation of 1. So the overall severity score is 81 in that case. We will then cross that with the occurrence on the batch. So that will be driven by the root cause analysis. In that case, we identified one root cause that allowed to consider that it was an isolated event. So we didn't have any huge contamination on the batch. The inspection data were typical. And we did also a check if other similar particles could have been observed on the batch or on other batches that were manufactured at the same time. In that case, nothing else was detected. So the quotation regarding occurrence was low. So then we cross the severity and occurrence that allow to determine that the risk is low. We then evaluate the detectability of the particle. Doing that, we use qualification data. So in our case, it was a very high detectability that allowed to give a quotation of 1. So if we cross all this, we consider that the final overall risk is low, for that specific event, and that will be used in the overall investigation to make the decision on the batch. So we could apply that on different type of events. So I have another case study that is similar to present. Scott, please, thank you. So here it is exactly the same principle, but the entrance way was an atypical particle weight. Sorry, Scott, I can no more see this. Thank you. So we had an atypical particle weight for a typical particle. So in that case, atypicality was linked to the high level of particle in the batch. So here again, we evaluated the severity. So the final quotation was 45. That is considered very low. We got also the occurrence of the defect. In that case, it was quoted 9 because we have an atypical level of particle in the batch. So regarding this severity and occurrence, we consider that the risk is middle. And finally, we cross that risk with the detectability. In that case, the particles were detected in a difficult to inspect product. So we consider by default that the detectability was low. So it was scored 9. So based on all these elements, we considered that the overall risk on the batch was middle, and we consider this information to make the decision on the batch again. So just to conclude on this, it is really a really helpful tool that mainly allow first to standardize the decisions. Since we have this tool in place, 99% of the decisions are really standardized. Of course, you still have some outliers with totally atypical events that you should discuss. But for most of the cases, it's really helpful to make the decision on the batch.
Great. Thank you very much, Valerie. And moving on to back to Antonio again for our conclusions. You're good to go.
Perfect. To sum it up, again, we can only repeat, it is really a very, very helpful tool, and it's a vital part of particle investigations. So this is really something that you can use in a standardized manner going forward. Whenever you have particles that you need to assess, but you want to use this methodology, which is based on, current knowledge, has been, tested a lot already in the industry. In the design phase, it was also tested a lot, and it was also verified by additional medical experts. So in the end, it will not be the only tool that you are going to use. It is going to support your overall risk management process and your understanding of the potential overall risk. But what it does, though, is it allows for this risk-based evaluation in a very, very standardized manner. It takes into account the severity, the occurrence, and also our capability of detection in the process to assess them in an objective manner repeatedly for different kinds of particles. So whenever you use the tool, you can be assured that you have this standardized approach and you don't come up with, random assessments overall. It's also very important, and we have seen this also in the case studies, the tool can be applied across different companies. It can be applied across different products. It is very flexible to be used, but also it can be customized to individual company needs based on, your understanding of risk, your understanding of quality levels, your specifics when it comes to the products and the routes of administration and your understanding of what is the quality that we are actually accepting from us. So highly customizable tool, but still in the basis, it is very much aligned and standardized. So with that, we're concluding the presentation of the tool. Thanks a lot for giving us the chance to present this to you.
Thank you very much. Just before we move into the Q&A, I did just want to highlight who was involved in the in developing the approach. And I don't want to go through everyone that's on screen here individually, but just to highlight the fact that the standard methodology, both the original proof of concept and the adapting the approach for investigations, was a collaboration throughout the whole team, the whole workstream team. But amongst those, of course, some do more work than others, just as bandwidth allows, and a list of names is available here and in the publication itself. So I just want to thank everyone who was involved in creating the methodologies themselves in plural, and also to Marcel, Antonio, and of course Valerie for their presentation today. So thanks to you all.